So coming to my next part, which is in continuation, how to plan and do a preoperative detailed workup. So indications are you have to choose the patient who has myopia, hyperopia, astigmatism, or which is a case of stable keratoconus, and they are being used off-label in other special conditions like post-refractive surgery patient as a bioptics, post-cross-linked patient, post-keratoconus, post-keratoplasty patient, and as a piggyback lens to correct the residual refractive error, and in some cases of pediatric anisometropia, which are of very high power, maybe more than 18-20 diopters at that young age. In that cases also, in those cases also, where anatomically you find that they are their development is there, and then we can do it for the presbyopia correction. The contraindications are to be remembered, and they are very important. If they have any lens opacity or the zonal dialysis, coloboma, or pseudo exfoliation, pigment dispersion, or there is a progressive refractive error, or if there is a pre-existing corneal endothelial dysfunction is there, or they are harboring glaucoma or chances of glaucoma are there, angle chamber is less than grade 2, and anterior chamber depth is also less than 2.8 millimeter, then we should avoid it. And in pregnancy and nursing mothers, and other than this, corneal degenerations or dystrophy, rubeosis, irides, uveitis, iris atrophy, coloboma, lens, retinal or macular pathology, and new vascularization of iris or the retina. In such cases, this should be avoided in any case. Prerequisites are that the age which is recommended by STAR is 21 and up to 45 years of age. We can do it early when the refraction is stable for more than 1 year. LASIK rejects cases due to high myopia, thin corneas less than 500 micron, in dry eye patients, large pupils, excessively flat or steep cornea where we cannot do the corneal surface procedure. In clear crystalline lenses, the lenses are clear and the intolerance of contact lens or spectacles are seen, and appropriate pupil size is there, which is very important because you can face a litigation later. And there should be a minimal endothelial cell count of more than or equal to 2000, and with the age and angle size and anterior chamber depth, there is a table here. And adequate crystalline lens rise should be seen on ASOCT. So all these investigations are done, uncorrected and best corrected visual acuity, refraction, manifest and cycloplegic, slit lamp examination, mainly for the cornea and lens, IOP, no glaucoma, angle should remain open, corneal topography, tomography and keratometry are done, which is very important. Specular microscopy should be done. Fundus examination should be normal peripheral retina or treated by photocoagulation. Corneal, and the two important things which are specific to this procedure is the measurement of horizontal white to white distance and the anterior chamber depth, which should not be less than 2.8 millimeter. And this anterior chamber depth, mind it, should be from the measured from the posterior surface of the cornea. We have to measure the internal anterior chamber depth. Why the corneal topography and tomography are important? Because this gives us the cylindrical power and at the same time axis of the cylinder, and we can know the steep or flat keratometry, and it helps in ruling out progressive ectasias and cases of suspects of corneal keratoconus, and it gives internal ACD and horizontal white to white measurement, which is imperative to the surgical planning. Now, in keratoconus cases, topographically stable keratoconus patients can be selected and we can operate upon them, and there should be stable scans between 2 visits at 6 months apart. And in cross-linked patients, the one can plan in Phakic IOL in stable refraction if it is attained in last 3 consecutive visits, and there is the central cone and clear central cornea, and keratometric values are less than 52 microns. So coming to the important aspect, which is specific measurement of horizontal white to white, how to proceed. we should believe me, I am myself is doing, and most of us are doing with the measurement by the digital caliper, which is on the right side, which are freely available, and the company people also help you in getting it. And this is the best way of measuring horizontal wide to wide diameter. Otherwise, we can do by OpScan, Pentacam, IOL Master, UBM, vernier caliper, or various autoreflectors also now they provide us. So horizontal wide to wide image you can see on the left side, which comes on the keratometers, and the right side is the UBM, which tells us about the sulcus to sulcus diameter. So we will discuss it later. So measuring the wide to wide, which is important aspect, should be done in a supine position under the microscope in a high resolution, and from middle of the limbus to the middle of the limbus on the other side, and pre-treat the eye with an aesthetic drop. This is what it is. It's a simple digital caliper. We are measuring it, and calibrate the caliper before every use. So this is how it comes. It is very, very simple. It hardly takes two minutes. You have to counsel the patient, and this is how the procedure, surgical procedure, is also done. So it is advisable to acquire the consecutive topography scans and the average wide to wide to be used for the Phakic IOL calculation, diameter size calculation. It can be between 10.5 to 13.5 millimeter. Less than this, ICL is not recommended. It is recommended that automated measurement is verified manually and with calipers for appropriate sizing. The company recommends 1.1 millimeter higher when the AC depth is less than 3.5 millimeter, and 1.6 millimeter higher when the AC depth is more than 3.5 millimeter. This is for your the mental calculation. When the company is suggesting you the plan, then you can check it this way. So various studies have been done to correlate between sulcus to sulcus diameter, which is the actual place where the lens will sit, or the horizontal wide to wide. But neither clinically meaningful nor statistically significant differences is achieved, and the Walt differentiates between the wide to wide measurement manually by the digital caliper or by the UBM. So therefore, sizing based on wide to wide remains the most popular and best studied technique. So why this is important? Because we get a vault of this lens over the crystalline lens. So ICL provides a vault. So the ideal sized ICL is, which gives a vault of 0.25 millimeter to 0.75 millimeter. So how to check it? We can check it with the thickness of the cornea. So our thickness of cornea we can see, and then we can see the distance between the posterior surface of the ICL and the anterior surface of the crystalline lens. So if this matches, so if our average thickness of the cornea is 500 micron, so this means this, which is nearly same or slightly more, so this patient has a good vault. Very good morning, President sir, please come here. And another star performer, which doesn't require any introduction here. Dr. Mahipal is also here. Please come, sir. And the ideal size should be between 2.25 to 0.75, which is like half the corneal thickness to 1.5 times the corneal thickness. This should be kept in mind, and on slit lamp you can easily see. And undersized ICL will cause there are high chances of anterior subcapsular cataract, and oversized ICL will lead to development of glaucoma and rise in the intraocular pressure. So this is what it is. A normal anterior, this is a vault on the left side, and a low vault which is seen on the right side. And if it is below this or the lens is touching, you have to explant the lens. So we should do the pupillometry, and ideal mesopic pupil size is less than 5 or between 5 to 6 millimeter, and it should be less than that. And ASOCT should also be done. It provides structural imaging of the anterior segment of the eye, and it provides accurate and repeatable values of the crystalline lens rise. And in few patients, when the crystalline lens rise is not appropriate, then the chances of development of the cataract is high, and development of glaucoma is also there. So we should check the crystalline lens size. The angle-to-angle measurements were found to have higher reproducibility than the white-to-white measurement on ASOCT. Some studies say like that. So UBM I have already discussed. So now I think most of us, we don't do measurement by the UPM. So I will not go into much detail. This is the kind of sheet which comes from the company, which you have to check for the power, what is there, which the patient is having. On the left side, you can see there is a 11.5 with 1.5 diopter cylinder at an axis of steep axis of 10 degree, and keratometry we should check. Corneal thickness is there, and white to white we have whatever we have measured is mentioned over there. And on the right side is the lens which they are recommending, and what will be the residual expected refractive error with the after the implantation of lens. And we should check for the size of the lens, which is 12.1 millimeter in this particular case. So this is a case which has got a thin cornea, 487 and 483 on the right. Although the power is less, but still better to do. And this is a high power, -9, -10.25, with the optimum thickness of the cornea, but the power is more, so it is a suitable case for ICL. Another case with the thin cornea, and the power is also more in both eyes. And this is the sheet which comes from the care group with the similar findings, and similar things should be seen. The advantages with the care group lenses, they are the smart toric lenses. So you just have to place the lens in 0-180 degree axis. So you don't have to place it you have to rotate it to one side 10 degree, this side, that side, which is the plan which will be given in the toric IOL platform. But these are smart toric lenses. So coming to the conclusion, this is the most important slide which tells us the 8 years old result, and this was published in 2021, recent this. And they say with the newer centraflow or with the central opening ICL and with the moderate to high metropia, in 8 years there is no change in the refractive error, no development of cataract, no change in the power, and the vision remains stable. So this is what just gives you a glimpse for the beginner who are apprehensive of starting the practice of phakic lens. To conclude, it's a technique which involves no blood, no pain, no hospitalization. It provides excellent cosmesis, correction of wide range of myopia, hypermetropia, and astigmatism. It's reversible. Just like LASIK, it takes 5 to 10 minutes in experienced hands. The quality of vision is usually better, and induced astigmatism is minimum. We get adequate tear film and no minimum chances of development of dry eye. Reduced risk of optical distortion. Rather, we get a better quality vision post ICL. Less risk of glare, halos, or double vision. Preserves accommodation and contrast sensitivity. Very stable over time with no regression. But the important things to be kept in mind is the important thing is that the pre-operative planning and workup is very, very important. And sizing related dilemmas and issues are always there, and it should be kept in mind. And with the improvements in material and design, the rate of complications have significantly reduced. Development of cataract post centraflow lenses have decreased markedly, and even with 0.25 millimeter vault, we have seen that there is no development of or minimal development of cataract. The possibility of complications and the benefits have to be weighed in each case individually, and patients should be informed about the options available before finalizing on the preferred surgical treatment options. I thank you for your patience, Harry.